the pregnancy and the kidney. And I would like to request Professor M.A. Muthusethupathi sir, Ananth Karumanchi sir to chair the session. Dr. S.C. Das sir will join us online.
Shall we start? Yeah. Thank you. To introduce,
do you want me to share the screen and do a presentation live? Hi, my name is Ananth Karumanchi. I'm going to be talking to you today about renal diseases and pregnancy. So during pregnancy, there's tremendous increase in blood volume. Almost about a quarter of the cardiac output goes to the fetus. And so as a result of that, and with the placenta secreting hormones, there are physiological changes in renal function that as nephrologists we need to be aware. And there's constant crosstalk between the kidney and placenta throughout pregnancy. So some of the physiological changes that occur in pregnancy that we need to be aware are there's a physiological hydronecrosis. Perhaps this is thought to be due to progesterone-mediated smooth muscle relaxation that occurs during pregnancy. Since the GFR goes up, there's a slight increase in proteinuria. The total proteinuria in pregnancy can be as high as 250 milligrams per day. And again, because the GFR goes up in pregnancy, the serum creatinine can drop from 0.8 to 0.5 to 0.6. So a serum creatinine in a pregnant woman of 1 or 1.1 could represent serious acute renal failure. So this is a summary of some of the physiological changes that occur in pregnancy. The big ones being the glomerular filtration rate shown here that goes up to almost as high as 150 to 200 mils per minute. And then in response to that, you see the serum creatinine drops to 0.5 or 0.6. The other sort of physiological changes that occur in pregnancy is a drop in serum sodium. So physiologically, the normal serum sodium in pregnancy can be in the mid 130s. And so a serum sodium of 145 in a pregnant woman can represent diabetes insipidus. Often, I should say less often, you could see patients with an enzyme made by the placenta called vasopressinase that can lead to nephrogenic DI, where patients can present with serum sodiums of like 144 or 145. There's also a drop in PCO2. This is also largely thought to be due to progesterone-induced increase in respiratory rate. Again, while you interpret blood gases, nephrologists need to be aware that these physiological changes are part of normal, pregnancy. So the major change, as I mentioned, during pregnancy is an increase in plasma volume that is thought to be due to an upregulation of the renin, angiotensin, aldosterone system. But what's very important is that in preeclampsia, this system is suppressed. And in fact, the plasma volume is depleted in women who have or subsequently develop preeclampsia. These slides are taken from a review article written by Chris Bayliss. Is shown here on the left is the mean blood pressure changes in normal pregnant women and then women with preeclampsia. You can see that the women who subsequently get preeclampsia have significantly higher blood pressure changes, and they start. The change in blood pressure can be noticed even as early as first trimester, but the most dramatic changes are seen often in the third trimester. But importantly, there's also a decrease in plasma volume that starts quite early in the women who subsequently develop preeclampsia, and this persists throughout and is maximally seen, at term. So the key points to remember are that patients with preeclampsia have a suppressed intravascular volume, and they also have a suppressed renin-angiotensin system as compared to a rise in a renin-angiotensin-aldosterone pathway in normal pregnancy. So how do you estimate renal function test, renal functions during pregnancy? A lot of the equations have not been validated in pregnancy. For example, the MDRD equation has not been validated in pregnancy. There's been some studies on cystatin C that measurements as a better marker of renal function, but the gold standard is really continues to be a 24-hour creatinine clearance. Likewise, often you'll see obstetricians ordering 24-hour protein, and then more and more there's data suggesting that protein creatinine ratio is just as good as 24-hour protein to monitor for the onset of preeclampsia or to monitor worsening of chronic kidney disease. What are the various hypertensive disorders of pregnancy? I think that the ones that as nephrologists will be often called to see are patients who have chronic hypertension, who get pregnant and they need adjustments in their blood pressure management. You can also have women present with a transient hypertension of pregnancy. Often we refer to that as gestational hypertension, where they don't have evidence of any other end organ damage. And these patients, their blood pressure often gets better after delivery. Many of these patients go on to get chronic hypertension later in their life. We also often see chronic hypertensive patients who get complicated with preeclampsia, and then of course de novo preeclampsia, which is a form of secondary hypertension that's largely due to a placental pathology. So why is it it's important to take care of chronic hypertension? Is that because these patients are at very high risk for pregnancy complications, in particular superimposed preeclampsia. As much as a quarter of these patients go on to get significant preeclampsia, and this is a 3 to 5-fold risk over, let's say, patients who have no blood pressure at baseline. Are there any parameters amongst chronic hypertensives that would tell you they are at particularly high risk? Really, the bottom line is that if they have pre-existing proteinuria, that adds some risk to it. But really, it's the uncontrolled blood pressure that contributes the most risk. So many epidemiological studies have now supported the idea that women whose blood pressures, generally diastolic blood pressure, is greater than 100 or so, they have a twice as much risk for getting superimposed preeclampsia as women whose blood pressures are lower than diastolic blood pressures are lower than 100. This is a classic study that many of the obstetricians use this. I think that if you do a 2x2 table, and of course shown in the graph are presence of stillbirths, which is a complication of baby not getting enough blood flow, and you can see as the diastolic blood pressure goes up, the rates of stillbirth goes up. Likewise, as proteinuria goes up, the rate of stillbirth goes up. But most importantly, in women who have significantly high diastolic blood pressures and also proteinuria, they have the highest risk of stillbirth. So to really ask this question, this was a major clinical trial, published in the New England Journal a number of years ago by Laura McGee's group. They looked at essentially women, chronic hypertensive women, and treated them with either tight control, where the diastolic blood pressures were, maintained around 85 millimeters or so, and less tight control, where the diastolic blood pressures were maintained around 100 millimeters or so. And really, while this was one of the most well-done study in pregnancies, the primary outcome, which was fetal loss and or fetal NICU requirements for babies for more than 48 hours or so, there was no significant change in the primary outcome. But importantly, if you look at the other secondary outcomes, for example, a big finding that they noted was patients with severe hypertension, meaning women who have at least one episode of blood pressure greater than 160 over 110. And you can see that patients, chronic hypertensives maintained with a tight control had lower risk of severe hypertension, not surprisingly. And you might wonder, why is that important? The reason that's important is that the ACOG and many other obstetric societies now recommend delivery for patients who have severe hypertension. And so, as you can imagine, if there's higher incidence of severe hypertension in the less tight control group, they're more likely to be delivered, leading to iatrogenic, prematurity. So the key point of this study is that tight control reduces the risk for severe hypertension, which is a key point for obstetricians for delivery. However, the primary outcomes in this study, adverse outcomes related to the baby and mother, were no different. What are some of the antihypertensives that as nephrologists we need to be aware to use or not to use? The major finding here is that most antihypertensives are relatively safe to use. The ones that have been extensively studied is methyl-dopa, which is a drug studied in the 60s and 70s. There's been a lot of data, but labetalol and nifedipine are the most common drugs used in the United States, and these drugs can be used both for the short term as also for the long term. They're also available as an IV drug for acute short-term reductions, and they've been, there's quite a bit of data demonstrating safety for these drugs. As a second line, other drugs like hydralazine or diltiazem can be used, particularly in women with preeclampsia. Diuretics are avoided generally because the plasma volumes are already low. But if a woman had chronic hypertension and her blood pressure was stable on let's say hydrochlorothiazide, they could be continued. The class of drugs that are to be avoided in patients during pregnancy are ACE inhibitors and ARBs, largely because these drugs cross the placenta to the fetus, and they can cause significant teratogenicity, in particular, particularly when they're used in the third trimester or early second trimester. They've been associated with impaired renal development. What about glomerular disease in pregnancy? So obviously, the type of glomerular disease matters, but also the degree of renal insufficiency associated with these glomerular diseases also matters in terms of outcomes. So this is the classic study by John Hazlett that was published in the New England Journal in the late 1990s, where he studied 82 pregnancies at Yale. And the bottom line is that you could see in this study, over half of the patients, did fine. So these are chronic kidney disease patients, and their creatinines at the end of pregnancy, were stable. But about, 23% of patients, the creatinines worsened during pregnancy, and in about another 20%, the creatinines worsened, in the postpartum phase. And so this data is now, combined with other, case reports, has been now summarized in this paper in Kidney International, published in 2017. The bottom line is that a creatinine above 1.4 or so is generally thought to be bad for pregnancy outcomes. So you can see if you have a creatinine of, 1.4 or higher, not only are there very high incidence of pregnancy complications, but these patients also have at least a 25% loss of renal function. And if the start baseline creatinine is as high as 2.8, you can see more than half of these patients have significant renal function loss during pregnancy or following pregnancy, and many of them end up with end-stage renal disease. So really, the advice here is that for chronic kidney disease patients, you want to have your creatinine less than 1.4. There's still an increased incidence of pregnancy complications like preeclampsia, but it's manageable. In general, they have over 90%, 96% increase in successful obstetric outcomes, and their loss of renal function is quite low when their starting renal function is less than 1.4. What about early stages of CKD? Creatinines, let's say 1 or 1.1. Do they have any differences in changes in pregnancy outcomes? And this is now data published from Piccoli et al. That have summarized in many, many papers. As you can imagine, as you can see here, even early stages of CKD, associated with high incidence of or relatively higher incidence of preeclampsia, for example, as compared to healthy women, and there's higher incidence of many of the pregnancy issues like preterm delivery, C-sections, etc. Not as high as the more moderate to more severe CKD, but it's important to realize that even the milder forms of CKD are associated with pregnancy complications. What about the type of CKD? Really, for the most part, diabetes is sort of the one disease that has a twofold excess risk of, in this case, preeclampsia over, let's say, other forms of CKD for the same degree of renal function. And you can see here diabetic nephropathy almost twice more preeclampsia compared to, let's say, chronic hypertensives or renal transplant patients. Again, this is thought to be due to the fact that diabetes affects the vasculature, and preeclampsia is a disease of the endothelium. And so perhaps the susceptibility, for preeclampsia is lowered in this particular population. So as nephrologists, what are some of the things that we might do for patients with chronic kidney disease? Obviously, at all stages, they are associated with higher risk of pregnancy complications. So really, some of the things that we normally would do for pregnancy, like folic acid and calcium, need to be supplemented in these women. Importantly, because they are at high risk for getting pregnancy complications. Ideally, you would want to start them on low-dose aspirin, even as early as first trimester. And you try to manage the blood pressures to keep the blood pressures around 140 or 90. Particularly, as I mentioned to you, that it's increasingly recognized that keeping their blood pressures under 140 or 90 essentially associated with less incidence of episodes of severe hypertension, which might end up being associated with iatrogenic preterm delivery. The acceptable agents for managing blood pressure in patients with chronic disease are, as we discussed, labetalol, nifedipine, and/or methyl-dopa. And again, RAS blockade needs to be avoided. And in transplant patients, we'll talk a bit later. Generally, the safe immunosuppressors are prednisone, calcineurin inhibitors, and azathioprine. What about AKI? AKI we know is a risk factor for chronic kidney disease, but what about if a woman has had a prior history of AKI? Is that itself a risk factor for some of the pregnancy complications? This is a wonderful epidemiological study done by Jessica Tangren at the Mass General Hospital, where she looked at over 100 patients with a history of prior acute kidney injury and compared them with controls over a period of 10 years. These are patients who presented at a single institution in Boston. And you can see that at the time of pregnancy, they've had their renal functions are basically identical. And yet, when you follow these patients, the women who've had a prior history of preeclampsia, a prior history of AKI, for example, have more preeclampsia, more pregnancy complications. So it's almost that these women remember the kidney injury and they have higher incidence of pregnancy complications. And these patients, even though the renal functions are normal, should now be viewed as high risk and treated as high risk with frequent monitoring of blood pressure, but also treatment with low-dose aspirin and referred to high-risk maternal fetal medicine specialist. What about diabetic nephropathy? This is, I would say, relatively common. More and more women with type 2 diabetes and type 1 diabetes who get pregnant will be referred to a nephrologist because they have, kidney disease. In general, if they have no overt chronic kidney disease, they do well. And so obviously, if renal functions are worse, they have a higher risk of pregnancy, complications. And it's known that the first trimester hemoglobin A1C, for example, predicts pregnancy complications. So ideally, what we would recommend in patients with diabetes is to have optimal glycemic control keep the hemoglobin A1C low, ideally less than 6.5. And if they were on ACE inhibitors or ARBs, to stop that, early enough so that the fetal kidneys are not exposed to these, drugs. And so this is a nice review by Kate Bramham, talks about diabetic nephropathy and pregnancy. And what is quite clear is that compared to other forms of kidney disease, if you have diabetic, CKD, you have twice more preeclampsia. Again, perhaps likely due to underlying, vascular disease, more preterm deliveries, and more NICUs. So these patients, need to be aggressively treated for their blood pressures and their blood sugars, adequately controlled. What about lupus? I think is that the influence of pregnancy on lupus is still debated. Maybe a third of those patients there's a chance of flare during pregnancy, and so ideally, advice you'd want to give to patients with lupus is to get pregnant when the lupus activity is quiet. And then if you have renal insufficiency, ideally you want to sort of keep the creatinines under 1.4 or so, for them to have a safe pregnancy. The higher the creatinine, obviously they are independent predictors of not only outcomes, but also long-term renal disease. You can treat the patients with steroids. Cyclophosphamide is not to be used during pregnancy. Hydroxychloroquine is being reported to be safe in pregnancies, and particularly for some of the complications of lupus, for example, for example, congenital heart blocks in the babies. Hydroxychloroquine has been shown to have particular efficacy in blocking some of those, antibodies that are responsible for these fetal complications. What about renal biopsy in pregnancy? It's really critical to differentiate, renal disease that's worsening from either lupus or diabetes that's getting worse from superimposed preeclampsia. Because many times, if you have a lupus flare, you can manage there with high-dose steroids and allow the woman to continue pregnancy. On the other hand, if this is superimposed preeclampsia, you'd have to, deliver them. And so the only way to really sort of differentiate these conditions is to do a renal biopsy. And this is probably the largest study, which has looked at renal biopsy in pregnancies. And can be done, obviously, as you get, as the woman gets more pregnant and as just with increasing gestational ages, the risk for complications is more. And so this is, less and less people use renal biopsies to differentiate, superimposed preeclampsia these days, particularly in the rest of the world, not so much in the United States, where there are biomarkers for preeclampsia that have been approved. It's clear that these biomarkers perform just as good or if not better than these renal biopsies. And so, if in those places where these biomarkers are available, they could be used to replace the kidney biopsy. But the question for us, where these biomarkers are not available, is this very simple question, which is that even though the risk is low, the question is, will it alter management? If we think that it's going to alter management, then perhaps biopsy is indicated. What about acute kidney injury? I think this is still a relatively common complication of pregnancy, where nephrologists are often consulted to evaluate the etiology of AKI. Shown here are a lot of different reasons to get AKI. For example, sepsis or preeclampsia or fatty liver. And a key differentiating point is the timing of the acute renal injury. If you have renal injury closer to term, or in the third trimester, you're thinking about preeclampsia. Whereas if you have AKI in the first, trimester, you're thinking about, septic abortion, for example. But also if you have renal failure post-delivery, you're thinking again of things like a TMA or a postpartum hemolytic uremic syndrome. So the timing of renal failure can help us sometimes differentiate between what are the causes of renal failure. This is a large study from India that looked at the causes of AKI in looking at about 132 patients or so. And you can see about half of them are pregnancy-specific complications, like preeclampsia, acute fatty liver pregnancy. But the remaining are due to pregnancy complications, primarily sepsis, or sometimes, postpartum hemorrhage, where a woman can lose a lot of blood, and this would be a sort of hemodynamic shock leading to AKI. What about TTP-HU as a pregnancy? This is, not an uncommon complication that can be seen, particularly in the peripartum period, roundabout prior to delivery or immediately after delivery. And what's important to know is that you look for, this is largely, again, thought to be due to large von Willebrand multimers that are perhaps due to autoantibody or some sort of genetic etiologies. And what's important is that it's important to sort of correctly diagnose this condition, because one can treat these patients with some of these newer complement inhibitors, particularly using eculizumab. There's been several case reports now. If you can diagnose, in patients with, peripartum atypical hemolytic uremic syndrome, that they have been successfully managed with eculizumab. We can also use plasmapheresis if people think it's due to autoantibody against ADAMTS13, for example, or an autoantibody to some of the alternate complement pathways like factor H. One could consider pheresis as well, and that's generally safe in pregnancy. What about dialysis in pregnancy? I think both hemodialysis and peritoneal dialysis have been used in pregnancy. For chronic kidney disease patients and who end up on dialysis during pregnancy, or for acute renal failure requiring dialysis. In general, you want to initiate dialysis early, so you don't want to wait for a woman to get, for example, severe uremia, because often that'll have bad fetal complications. And so, initiate dialysis early. Even when the BUN hits around 50 or a creatinine is around 3.5, you start dialysis. And the difference between non-pregnant state and pregnancy is that in pregnancy, in contrast to 3 treatments in the non-pregnant state, you want to do more dialysis, 4 to 5 treatments, so you get keep the BUNs less than 50 to avoid this, fetal polyhydramnios. And so the only best way to do is either intensify or increase the duration of treatment, or actually do 4 to 5 days a week of dialysis. Peritoneal dialysis, not as much data compared to hemodialysis. You do again multiple exchanges, and you reduce the volume to avoid abdominal discomfort. So this is data from the Australians and New Zealand data, registry data. If you look at pregnancies, particularly, you see that compared to general population, of course, if you have a renal transplantation, your pregnancy live births per 1,000 person years is substantially lower. But if you're on dialysis, it's significantly lower. But you do still see a small percentage of patients who are on hemodialysis who get pregnant. And we now have a lot of data, as to how to manage them. And the big sort of change is that you dialyze them aggressively and keep the BUNs to, lower than 50. So this, beautiful paper by Sylvie Shaw that was published a number of years ago. We've always been taught that because of hyperlactin or other endocrine, abnormalities in pregnancy, the endocrine abnormalities of end-stage kidney disease, that once you're on dialysis, you're unlikely to get pregnant. That's true, but what Sylvie Shaw was able to show is that the pregnancy rates are actually higher in some of the minority communities, like African Americans, Hispanics, compared to, let's say, white patients. Importantly, if your ESRD is due to non-diabetes etiologies, for example, if you had underwent nephrectomy for a malignancy, you're more likely to get, pregnant. The pregnancy you're less likely to get pregnant if you're on PD. And this is, again, the numbers are small. but generally something to think about, that it is still possible for dialysis patients to get pregnant, and when they get pregnant, you sort of intensify dialysis. So why do we say that intensification of dialysis is important? This is a large systematic review looking at a number of different groups. You can see on average, most groups do at least 15 hours or, or at least 20 hours. Some groups, like in Toronto, they do 40 hours. And I can tell you that, that there's an inverse correlation between outcomes and the adverse outcomes and the number of hours per week of dialysis that are used in these patients. So this, for example, is prematurity. You can see this is inversely correlated with dialysis intensity. The longer the hours of dialysis, the less the proportion of babies born premature. Likewise, SGA, or small for gestational age, babies, again, inversely correlated with dialysis intensity. And so the more sessions, more treatments, more favorable outcomes. And so a traditional thinking was that patients with dialysis, as it's shown in this registered study from New Zealand and Australia, is that the compared to age-matched healthy controls, the incidence of successful pregnancies is quite low. So this paper from Toronto has really, changed that thinking now, that if a woman wants to get pregnant and she's on dialysis, if you aggressively increase the dialysis prescription to either more days on dialysis or just more hours on dialysis, in this case, this was a conversion from a conventional hemodialysis to a nocturnal dialysis, where she was getting, 5 to 6 treatments per week, almost as high as 7 hours per week. And this patient, after switching from a standard hemodialysis to nocturnal dialysis, got pregnant. And so this really led to a sort of a mini revolution in Toronto, where many patients were referred to Toronto. Many women on dialysis wanted to get pregnant, went to Toronto to get their sort of dialysis prescription changed. And we now have quite a bit of data from the group suggesting that, in fact, the pregnancy, not only are the pregnancy rates higher, but their outcomes are significantly better with this enhanced sort of dialysis prescription. So this is a paper by a classic paper by Michelle Hladanovich's group from University of Toronto, comparing Toronto experience with the United States experience. And you can see that the live birth rate, using this sort of intensive dialysis, is significantly higher, 83% compared to 50% in the US. But also among the patients, again, looking at the dialysis time, about 33 hours in Toronto compared to like 15 hours or so, almost a 2-week increase in gestational age, and also increase in birth weight. And in general, the percentage of low birth weights, was significantly, for example, in this case, significantly lower number of patients. Very low birth weight is only 6% compared to 29%. Again, these results weren't significant because the sample size was low. But in general, you could see overall the live birth rate and overall gestational age of delivery, and a trend towards reduction in very low birth weight in these patients who got more dialysis than the standard of care. So when you divide this group to tertiles, you can see that the patients who had the most hours of dialysis in the third tertile had the highest birth rate, almost 85% live birth rate. But also, the people who had the highest, dialysis hours in the third tertile, delivered later. Their birth weights were generally, higher, again suggesting improved fetal outcomes. So I think there's been a thinking among nephrologists that if you, had a pregnant patient, try to do as much dialysis as you can. To keep the BUNs lower than 50, and maybe do 5 to 6 days of dialysis, so that these women have better outcomes and particularly higher chance of live births. So the key points again on pregnancy and dialysis is that there's a in general, there's a lower likelihood of conception in patients, ESRD patients, but the rates rise if you intensify dialysis. These patients are at a very high risk for pregnancy complications. And the way you avoid that is, again, intensification of dialysis. The other points to remember is that the iron and EPO requirements are increased primarily because you now have a fetus that needs to get accounted for. The experience with PD is unfortunately less. There's less experience with PD, but the volume of exchanges generally to keep up the clearance, you generally go down with the volume of exchanges, but you increase the number of exchanges. This way to keep up the or increase in the clearance. What about renal transplantation and pregnancy? Obviously, many young women get transplanted. They want to get pregnant. The ideal time is when the allograft function is stable. And what you want to do is you optimize the immunosuppressives, and then you explain to them the risks of pregnancy, and then you make sure that they have a follow-up not only with nephrologists but also with the maternal fetal medicine specialists. So these are some of the guidelines from Susan Howe's review. I don't think anything has changed. In general, I would say that you don't want to get them. These women should avoid pregnancy during the first year after transplant, just because there's a lot more rejections and infections during that period. So they need to be stable. Ideally, the renal function's got to be less than 1.3 or so. And ideally, you want the blood pressures and proteinuria to be adequately managed, and they want to be less than 140 over 90, and they should be on a prednisone, azathioprine, and cyclosporin. And you want to avoid some of the newer ones like sirolimus or Cellcept because they're teratogenic. But essentially, if you can switch them to steroids, cyclosporin, and Imuran on a stable dose, you can. They generally they do well. If they do get rejections, you can use some of these high dose steroids or OKT3. But again, data on some of the newer drugs for rejections just simply don't exist. What about donors? This is a very interesting sort of relatively nuance in this area. The women, particularly in the childbearing age, if they were to donate the kidneys and they get pregnant, there's almost a twofold increased incidence of preeclampsia or gestational hypertension. This again came from Canada from a large registry study. This has been now confirmed in the Scandinavian registry as well. So it's quite clear that women who who've donated kidneys, if they do get pregnant, there's a higher incidence of preeclampsia. So the fortunate part is many of them get very mild preeclampsia or term preeclampsia, and not really severe early preeclampsia. But this is something that you need to counsel and let the women be aware that there's a risk for preeclampsia, albeit mild, and generally, again, this is individual decision as to whether they want to donate the kidneys or not. But the general thinking is that these patients are high risk for pregnancy complications, and the general thinking is to sort of not take kidneys, from these patients. What about preeclampsia or eclampsia? This is a secondary form of hypertension that occurs in pregnant women, primarily in the third trimester, presents as new onset hypertension and proteinuria. There's a number of risk factors. The most common risk factors, of course, is prior preeclampsia or things like antiphospholipid antibody syndrome or family history of preeclampsia. But with all the risk factors out there, the vast majority of preeclampsia really present de novo. In other words, they have no prior sort of risk history or risk factors, and they get preeclampsia. And a lot of this is thought to be due to an abnormal placenta, but the placenta doesn't sort of invade into the decidua deeply, and this placenta is very shallow, and this shallow placentation leads to placental ischemia, and a bit like renal artery stenosis, the ischemic placenta releases molecules into the maternal bloodstream that in turn induces this secondary form of hypertension and vascular disease in the mother. And there's been a number of molecules that have been characterized, but this one particular protein called soluble FLT1 which is the endogenous vascular endothelial growth factor inhibitor, is thought to be both sufficient and necessary to induce this hypertension, proteinuria in the mother, with other maternal complications like HELLP syndrome or eclampsia with edema in the brain. And so how does this work? So essentially, normal pregnancy, you have these growth factors made in the placenta, like placental growth factor and vascular endothelial growth factors. And these growth factors bind to the vasculature and keep the vasculature healthy. And in preeclampsia, you have excess of the soluble receptors that bind to these growth factors and essentially create endothelial dysfunction, as these endothelial cells are no longer seeing these growth factors. And this is particularly relevant in organs such as the kidney, the glomerulus of the kidney, or the hepatic sinusoids, which are largely, fenestrated vasculature, and they require VEGF for normal sort of maintenance of filtration. So you can imagine if you have an endogenous VEGF inhibitor like soluble FLT1 being made by the placenta and secretes into the maternal bloodstream, this would hit those organ beds such as the kidney, that's very dependent on VEGF for the normal sort of maintenance of the glomerular filtration. And so we now have these tests that can be these tests can actually measure the soluble FLT and the ligand, in this case, placental growth factor, in the bloodstream. And many countries around the world, including Canada and Europe, have these assays that are approved, and they are now clinically used to both rule out as well as rule in, preeclampsia, where the preeclampsia is now characterized by high S-FLT and low PLGF. It's unfortunately not yet approved here in the U.S., and they're still undergoing trials for FDA approval process. But the data from around the world is quite convincing that these, biomarkers, work with very high sensitivity and specificity, but more importantly, also differentiate preeclampsia from other, kidney diseases. So this was the large sort of the New England Journal paper that was published a number of years ago from Europe that looked at about 1,000 patients or so, and essentially what was shown in this paper is that if a woman comes in with high blood pressure or proteinuria or some suspicion of preeclampsia, and if you add a negative test, you almost have a 99% chance of not getting preeclampsia in the subsequent week, and more than a 95% chance of not getting preeclampsia in the subsequent month. So really, even in the absence of therapy, the way these biomarkers are used, at least in the rest of the world, is that as a rule-out test. And so we think that these tests, when they're available in the U.S., would have tremendous utility to help nephrologists and obstetricians, diagnose preeclampsia, but also for prognosis of preeclampsia, but also for a rule-in in terms of starting new therapies or testing new therapies in these pregnant women. So this slide shows a list of neonatal complications by gestational age. You can see that when the babies that are born at 24 weeks, they have a higher incidence of respiratory distress, sepsis, intraventricular hemorrhage, and necrotizing enterocolitis. A baby that's born at 34 weeks, these complications kind of plummet. So even in the absence of a therapeutic intervention for preeclampsia, it's important to accurately diagnose the disease. Right now, if you had a lupus or a diabetic patient that's present here, and if you didn't have a renal biopsy or a biomarker test that allowed you to tell you who's got preeclampsia, and many of these patients can get delivered thinking it's preeclampsia, and you're left with all these iatrogenic complications from prematurity. So accurate diagnosis, and delivery for preeclampsia, but for extension of pregnancy or prolongation of pregnancy for the non-preeclamptic patients is crucial, because you want to avoid these sort of complications in the baby. But also from a therapeutic standpoint, if you had a treatment for preeclampsia, the ideal treatment would be something to just really be applicable in patients between 24 weeks and let's say 30 weeks, and try and push them by a few weeks and have these babies deliver 32 weeks. So many years ago, my colleague, Dr. Tadani at the Mass General Hospital, proposed this idea that if soluble FLT1 protein made by the placenta is responsible for the hypertension and proteinuria, why not deplete them in women with preeclampsia using apheresis, a targeted method of removing protein. In this case, this particular column was approved for familial hyperlipidemia, and this column made out of dextran sulfate, which looks like heparin, is negatively charged, and soluble fluid is positively charged. The idea is that could you actually lower soluble fluid and see if that would lead to extension of pregnancy? So in a small trial done in Germany, Dr. Terani and his group was able to show that even a single treatment, or even was able to reduce sFlt1, and compared to contemporaneous controls, you can see on average the patients that got treated with this apheresis had an extension of pregnancy by a week or so. In a few patients, when Dr. Tadani was able to do multiple treatments, you can see here, for example, a woman presenting with very high soluble FLT1 gets a treatment, and a protein is lowered to by about 25% or so. And there's a reduction in proteinuria, and there's a stabilization of blood pressure. And every time she gets the treatment, you can see there's a stabilization of blood pressure and a reduction in proteinuria. But importantly, simply not allowing the soluble fluid to go up to very high levels, keeps this mom pregnant, and as a result, a baby that comes out almost 3-4 weeks later from the initial diagnosis. So this treatment still needs to be validated in a randomized controlled trial, which is currently ongoing in the UK and in Germany. And so we don't have answers for that now, but it's quite promising that this type of nephrological treatment of depleting soluble fluid might be useful in patients with severe
Dr.
or
Ananth, you're
very
going to have to wrap up.
preeclampsia.
We are running short of time.
So let me summarize what I've shared with you so far. Basically, the 3 key points are that during pregnancy, there are physiological changes to kidney function and in the vascular system. There's drops in serum creatinine, and there's decreases in serum sodium, and there's decreases in blood pressure. And so, as nephrologists, we need to be aware of that. In addition, we need to be aware of some of the antihypertensives and immunosuppressive medications that can be used and that need to be avoided. For example, to avoid the ACE inhibitors and ARBs, and to avoid cell-septal rapamycin among the transplant patients. And in general, patients with chronic kidney disease, once their creatinines are above 1.4, pregnancy is not advised because they have very high incidence of pregnancy complications, but also worsening of kidney disease. But for those patients who have, mild to modest, renal dysfunction, they get pregnant. It's important to keep their blood pressures well managed, less than 140/90, and a low dose aspirin to prevent, preeclampsia. And if the renal function gets worse and they need dialysis, then intensive dialysis to keep B1s less than 50 is critical to improve fetal outcomes. But the exciting thing in this field is that we think that this particular complication of hypertensive complication of called preeclampsia, we have a better pathophysiological underpinnings. And I think that it's important for us nephrologists to understand the implications of knowledge, how potentially these biomarkers that are intimately tied with the biology, like sFlt1 and PLGF, may be useful for both early diagnosis, prevention, and down the line, a treatment of preeclampsia.
Thank you, Dr. Ananth Karumanchi, for that lucid and pretty extensive talk on pregnancy and renal disease. A couple of tidbits about Dr. Ananth, since we weren't able to introduce him at the beginning. He passed out of Kilpauk Medical College in 1992. And the other fact is that Karumanchi is a village in Guntur district of erstwhile Andhra Pradesh. We won't be taking questions because we sort of are short of time and we overran this session. So we'll close the session here. Thank you.
Thank you very much.
Thank you for a very comprehensive, clear exposition of the topic. Thank you very much.
Thank you, sir. We'll move on to the